Now, may I please request Dr. Kanti Dutta to present his talk.
Is the screen visible?
Yes.
And am I audible?
Yes, you are visible, sir.
Okay. So I shall be discussing according to the topic already discussed by Dr. Moinak, that a 56 years old lady presents to the emergency with with a history of worsening heart failure, basically with a tachycardia. It may be sinus, it may be atrial fibrillation. Blood pressure is 120/70, JVP is raised, denoting that she is having right ventricular failure too. Echo not done. So in that context, being a cardiologist, we have to investigate whether the ejection fraction is important in hospital or post-discharge, how we should diagnose a case of acute decompensated heart failure, and how should we treat in hospital, and we should prepare her for a post-discharge summary as well as the relevant data also, which is relevant to prevent the heart failure related rehospitalization prevention too. So our goals will be to reduce the mortality, to reduce the heart failure related, CV related rehospitalization, and to prevent the worsening heart failure too. Not only that, we have to improve the quality of life of her too. So if I discuss the most of those patients presents to the emergency with the acute decompensated heart failure, almost more than 50% of them, specifically the elderly ladies, are presenting with the heart failure with reduced ejection fraction, and heart failure with mid-range and preserved ejection fractions are almost near about 40 to 50%. So to classify the treatment, definitely if we go to the McCrory and Baker's article, definitely the four important drugs that we all know, the ARNI, the beta blocker, MRAs and SGLT2 inhibitors, these are the primary stay of therapy. And along with that, in the decompensated phase, the diuretics, preferably the injectable in worsening heart failure, is the standard weapons that we usually use. Now, if the patient is having ejection fraction after doing an echo less than 40%, we should classify accordingly the NOIHA class. And if the NOIHA class is 1 to 3 with an ejection fraction of less than 35% with a 1-year survival, we generally plan for her an ICD implantation. If the ejection fraction is less than 35% and her ECG is showing an LVBP with a tachycardia 2 with a history of pre-syncope or syncope, then CRTP or CRTD according to her fibrosis, which can be diagnosed by an MRI. If the MRI shows significant myocardial fibrosis, we go for an CRTD. But definitely we should screen her for an angiography beforehand placing an CRT. And in refractory stages, obviously cardiac transplant is the treatment of choice. Now, if I discuss the one by one the stay of treatment, definitely the ARNI, that is the angiotensin receptor neprilysin inhibitor in hospital, both the transition as well as the pioneer HF study has shown that sacubitril valsartan not only reduces the NT-proBNP level in hospital, but it has a beneficial effect to prevent the heart failure related rehospitalization as soon as we can start early, and we can up titrate the dose, should be done within 2 weeks to 6 weeks of interval. Now coming to the another important drug in heart failure with reduced as well as the preserved ejection fraction and mid-range 2, that is the glyphogene. The SGLT2 inhibitors should be started as early. Previously, we were afraid of starting the SGLT2 inhibitors in hospital. Now, after the study, the IMPULSE study and several studies of dapagliflozin 2, it has shown not only the IMPA but DAPA, it reduces the composite of death, the number of heart failure related events, as well as the heart failure related rehospitalization events too, specifically those patients with a systolic blood pressure of more than 100, which this patient is fitting with that scenario. Now, how to uptitrate those doses, how to uptitrate from straight away from these four drugs, that is ARNI, beta blocker, SGLT2 inhibitor, MRAs. Now we are shifting from an horizontal scenario to a vertical approach. That means, so from a vertical to a horizontal approach, that means we start all these four drugs together and generally try to uptitrate those drugs, keeping an eye obviously on the electrolytes that should be done within hospital, and we should adjust the doses. At least the half optimal dosage of the heart failure therapy should be tried before 1 week according to the strong HF guideline or data. So generally we try to increase the doses within a week or within 2 weeks. and we should reach the maximum tolerated optimal doses within 6 weeks of the therapy to achieve to reduce the not only the all cause mortality but to prevent the heart failure related rehospitalization. Now coming to the other drugs which are important in prevention of heart failure, obviously over and above the beta blocker, in spite of that the patient had heart rate of more than 100, and specifically if the patient is on sinus rhythm, if the creatinine is less than 2.5, we can straight away add ivabradine, which is a class 2A indication if over and above the beta blocker the target heart rate is not achieved. Now, in worsening heart failure, according to the Victoria trial, we all know vericiguat comes in the class 2B regimen in NYHA class 2 to 4 with a ejection fraction of less than 45%. Those with a recurrent history of heart failure hospitalization, as well as those who need IV diuretics. And specifically in the Indian scenario, in rheumatic heart disease, in patients with a difficult to treat heart failure with recurrent heart failure, lanoxin or digoxin comes in the class 2B regimen. PUFA is again in the class 2B regimen. We all know the Victoria trial. I will not go into the detail, but one thing to optimize is that it reduces the CV related death as well as the heart failure related hospitalization. We should start 2.5 milligram once daily doses as early and up titrate to the targeted dose of 10 milligram daily as early as possible. Now, there is a controversy regarding the issues of diuretics, specifically the IV diuretics. We all know that torsemide is a long-acting, furosemide is a short-acting diuretic. Which one should choose? Which one should be avoided? But here comes the Transform HF trial, which shows that these are similar. So, all-cause mortality and prevention of heart failure-related hospitalization was almost similar in both the torsemide as well as the furosemide arm. Now, if the patient had atrial fibrillation, paroxysmal or permanent atrial fibrillation, definitely if the ejection fraction is less than 40%, gradually we should start of treatment with the not only the rhythm control but rate control. But here comes the study. Cabana trial has shown that the primary endpoint that significantly reduction of the heart failure related hospitalization after significant ablation of these drugs of this atrial fibrillation is often achieved if we can definitely treat or ablate the atrial fibrillation in those patients. Now, which one is forgotten is the anemia. Anemia is the most important cause apart from the sepsis, which increases the heart failure related hospitalization. So we should not forget the iron deficiency anemia. According to the trials I shall be discussing, it comes in the class 2A indication that all patients must be replaced with an intravenous iron, be it a ferric carboxymaltose. It should be done within hospital within the first visit if possible. And according to the FAIR HF study, among patients with a chronic heart failure with iron deficiency 2, the therapy resulted in improved symptoms as well as the functional capacity over 24 weeks of therapy. So it should be started in hospital. The Ironman study over and above these studies has shown that injectable replacement of iron is definitely essential in the treatment of heart failure with reduced ejection fraction and to some extent mid-range ejection fraction too. Now coming to the ejection fraction of 40 to 49, that means in the mid-range group, definitely if the patient comes in the decongested therapy, we must evaluate them for the cause. The cause may be hypertensive, the cause may be valvular, the cause may be cardiomyopathy, cause may be several other causes too, which Sars was discussing previously. Now the standard treatment obviously starts with a diuretic if the patient is having decongestion, and here comes the crux that SGLT2 inhibitor comes in the class 2A indication. Over and above the ARNI, both the AC inhibitor, ARB and ARNI are still in the class 2B. MRAs are also in class 2B, but SGLT2 inhibitors are in the class 2A, both in heart failure with mid-range as well as the preserved ejection fraction. So in preserved ejection fraction, we must screen for the etiology first. If the patient is hypertension, if the patient is having CKD, if the patient is having coarctation, if the patient is having renal disease, we must treat the disease first. Then only we can treat the heart failure related hospitalization prevention too. So the most important drug again in heart failure with mid-range as well as preserved ejection fraction comes the Emperor preserved is the SGLT2 inhibitor. It not only reduces the NT-proBNP level in ejection fraction more than 40%, but it should be started in hospital and should be treated for a prolonged period for at least 3 months to achieve the maximum tolerated success rate to prevent the heart failure related rehospitalization too. Now, the most important in heart failure with mid-range or preserved is the amyloid disease, which often forgotten. So, in patients with the heart failure, recurrent heart failure hospitalization, we must screen them for cardiac amyloidosis. This is an important tool that we must screen them for serum and urine monoclonal light chain and bone scintigraphy to be performed to confirm the presence of transthyretin cardiac amyloidosis. So, the study has shown that tafamidis, that is in amyloid cardiomyopathy, was superior to the placebo, and it will be available in the Indian context within a couple of months. So it is now almost available. We can start tafamidis in hospital, those patients with a diagnosed of ATTR gene transformation. Now the follow-up, which is very important because mortality rises almost 50% at 5 years once the patient is diagnosed with heart failure. And here 1 year mortality, all cause mortality is almost 30% with the heart failure with reduced ejection fraction, and readmission rate is almost 30%. To prevent the readmission rate, we must achieve all those 4 drugs, specifically the 5 drugs, to the targeted regimen within 2 to 6 weeks of therapy, and it should be remembered that it should be continued until and unless there is a side effect like hyperkalemia or any other side effect like angioedema. So we should not reduce the dosage previously in the preterm basis to achieve the maximum tolerated target regimen, to achieve the maximum the achieved heart rate preservation too. And to optimize our outcome in heart failure in patients, we must give them an outpatient checklist before the discharge. It is an easy and used tool. The single page can be given to them so that they can do at their home too. There are several risk predictors too, that is the ST2, SCDC score, the Barcelona risk score, the central heart failure risk score. So all this scoring system can be done apart from the Framingham heart scoring system. This will help us not only the NT-proBNP level in the follow-up, but the scoring systems will also help us to prevent the heart failure related rehospitalization. So thank you very much for your kind listening. What do you?
Thank you, Dr. Soumya Kanti Dutta.